Department of Pediatric Gastroenterology, Nutrition and Endocrinology, Osaka Women's and Children's Hospital from Japan. Dr. Hagiwara finished his training in Japan from the JKE University School of Medicine and his PhD from Osaka University. He also did a postdoc at the University of California, San Francisco. Now let's welcome Dr. Shin-ichiro Hagiwara, who will talk about pediatric colonoscopy to the Masterclass.
My name is Shin-ichiro Hagiwara. It's a great honor to speak at first APPSGHAN Endoscopy Masterclass. Today, I'm going to talk about pediatric colonoscopy. I have no financial conflicts of interest to disclosure concerning the presentation. This is the outline of my presentation. My presentation is divided into 5 parts. After introduction, I will talk about a case presentation. In this section, I will ask you several questions. Please figure it out. Then, I will explain indications for colonoscopy. After that, I will talk about endoscope choice. Finally, I will show you technique for colonoscopy insertion and colonoscopy demonstration. Let's begin by introduction. Osaka is a prefecture of Japan, located in the Kansai region. Our hospital is located in the southwestern part of Osaka. The hospital has 375 hospital beds, including Pediatrics department and Perinatal department. In recent years, the number of endoscopy procedures in our department is increasing. Last year, the number of colonoscopes is over 130 colonoscopy, even during COVID-19 pandemic. Our hospital is Children's Hospital, which is well designed for children, as you can see. Pictures were drawn on the wall and ceiling on the hallway. This is MRI room. Upper pictures are PLCU floor, which has 12 beds. Lower pictures are operation floor. Moving on to the next section, let's take a look at the case presentation. The patient is 7-month-old boy. Body weight is 7 kg. He developed frequent diarrhea with severe abdominal pain for 1 month. Then he was referred to our department. Laboratory tests revealed anemia, CRP level and fecal calprotectin elevation. Stool culture was negative for pathogenic bacteria. Abdominal ultrasonography revealed the wall thickness of the entire colon. PedGI decided to perform colonoscopy for this patient. Here are questions. Number 1. What type of bowel prep should be prescribed? Number 2. What kind of sedation anesthesia do you use? Number 3. What type of endoscope is used for this patient? Let's look at what we actually did. Number 1. We administered only enema to the patient because he had frequent bloody diarrhea. Laxatives can cause side effects such as abdominal pain in this case. Number 2. We chose general anesthesia. It depends on local medical resources. Number 3, we chose GIF 1200N because body weight was 7 kg. This scope is ultra-thin gastroscope. Its diameter is 5.4 mm. As you can see, colonoscopy revealed longitudinal ulcers and round ulcers with skip regions. The patient was diagnosed with IBD unclassified. By further examination, he was diagnosed with IL-10 receptor deficiency, which is one of the monogenic IBD. As this case demonstrates, colonoscopy is a very powerful diagnostic tool. This slide shows the 6 elements of pediatric colonoscopy procedure. Especially, we have to be familiar with methods of sedation or anesthesia and type of colonoscope for pediatric colonoscopy as PET-GI. These are important differences between adults and children. I'd like to look at the next topic, indications for colonoscopy. This table shows common indications for pediatric colonoscopy. Diagnostic indications are chronic or profuse diarrhea, suspected lower GI bleeding, unexplained anemia, polyposis syndrome, failure to thrive, suspected GVHD. Therapeutic indications are polypectomy, foreign body removal, dilation of strictures, hemostasis. Follow-up indications are IBD, eosinophilic gastrointestinal disorders, and polyposis syndrome. Let's take a look at the following atlas of pediatric colonoscopy. These colonoscopic images showed typical findings of inflammatory bowel disease. The top rows of images are ulcerative colitis and Crohn's disease. The bottom rows of images are IBD-U and IBD accompanied familial Mediterranean fever. The top rows of images are jejunal polyp and Poitzier's syndrome. The bottom rows of images are colorectal cancer in 11-year-old girl and Campylobacter enteritis. You can see large shallow ulcer on Baughlin's bulb. As you can see, there are various colonoscopy images. I'm sure you agree that pediatric colonoscopy is a powerful diagnostic and therapeutic tool. Now let's move on to talking about endoscope choice. There are no published data to support colonoscope choice in children, but recommendations based on experience state that the lower weight limit for use of a standard adult or pediatric colonoscope is 12 to 15 kg. In children weighing between 5 and 12 kg, colonoscopy can be performed by using infant or standard adult gastroscopes. Children weighing less than 5 kg may undergo a successful ileocolonoscopy with ultra-thin gastroscopes, although this can be technically challenging because of the flexibility of the insertion tube. This table shows endoscope choice for colonoscopy in my department. Please refer to the table in your medical practice. The last topic is about technique for colonoscopy insertion and colonoscopy demonstration. Let's summarize key points for colonoscopy insertion. First, anatomy is important. Beginners need to understand which part of colon is fixed, which part is not. Transverse colon and sigmoid colon are not fixed, and you have to especially pay attention to insertion in sigmoid and transverse colon. There are several techniques for colonoscopy insertion. I want to talk about axis keeping shortening technique and making a loop and resolving it technique in this session. The principle of axis keeping shortening technique is to control the tip and the shaft of the colonoscope for propulsion, as it straightens the axis of the bowel by shortening the lumen through intubation. Light turn shortening is useful to perform axis keeping shortening technique. To minimize air insufflation and suction frequency is important to achieve total colonoscopy in this technique. This technique shortens the colon and allows deep insertion of colonoscope. Axis keeping shortening technique is ideal because it does not cause the patient any pain. However, it takes time to acquire the skill, and it becomes difficult to apply in case of poor bowel preparation. However, axis keeping shortening technique is not always possible in every patient. Sometimes axis keeping shortening technique is difficult with a patient who has long and complicated sigmoid colon. In this case, insertion by making loop is useful. This is done by pushing the scope and dissolving single loop. If the colonoscope is engaged in a regular sigmoid alpha loop, the reduction of the loop is achieved by simultaneous retraction and clockwise rotation of the shaft of the colonoscope. Slow withdrawal with clockwise torque can straighten this segment with subsequent progression towards the descending colon. Advantage of this technique is to shorten the intubation time to second. Disadvantage is that it is sometimes painful in patients during the procedures. In my clinical practice, I use a combination of two techniques. I'll show you colonoscopy demonstration. The patient is 80-year-old girl with ulcerative colitis. Body weight is 25 kg. Let me conclude by summarizing my main points. First, colonoscopy procedure consists of 6 elements. We have to familiar with 6 elements as PEDGI. Second, to choose right colonoscope is important. Third, major insertion techniques are axis keeping shortening technique and making a loop and resolving it technique. Thank you for your attention.
So let's move on to the next topic,